Hi, I just wanted to make this quick video to go over the coding case that we did last night in the lesson that did not come through in a recording. So this is the second pregnancy case that we had. And I just went over it last night. And for those who were unable to attend live, I wanted to share a recording of this case. So I've already brought it up, but this is from the week 2 cases, again, the last case. So our patient comes in with ruptured membranes, term pregnancy, sterilization desires. So let's look closer at this hospital course. The patient didn't have much in terms of contractions after the membranes were ruptured. Augmentation of labor was carried out, and she delivered a male infant, 6 pounds, 8 ounces. Postpartum, she was taken to surgery for that tubal ligation. She did require catheterization because she was unable to void, but was discharged because she was voiding satisfactory. Okay, final diagnosis is normal vaginal delivery with single live-born male infant and sterilization. The first thing I want to point out here is normal is not highlighted because code 080, which is normal delivering pregnancy, does not apply to this case. Remember, code 080 is only if the entire pregnancy and delivery was normal. This patient was not. It's not normal for some of the things that she had. So when we're coding this, that's again why that normal isn't highlighted in yellow, because she does not have a normal pregnancy and delivery. So let's look at why. History and physical, she's 39, and that is not normal. That's considered an elderly gravida. So anything over 35 is elderly gravida, and you code that only if you're coding the supervision of the pregnancy. So before the delivery admission, you could code the elderly gravida. Then ultrasound shows she's due about the 22nd of November. You can see it's only October, so we know she is early. The patient came to the hospital in contractions. She had progressed from a 2 to 2.5 and was 50 to 60% effaced. Heart tones, a couple decelerations. She desires no further pregnancy and has requested a tubal. So let's look down again. So here we go. Approximately 36-week gestation with ruptured membranes. Okay, both of those are not normal. A pregnancy should last, textbook is 40 weeks, right? Anything before the 37th and 7 day or 38 weeks is preterm. So we're going to code that as a complication. She also had ruptured membranes. Again, that's not normal. It's not normal for the membranes to rupture at 36 weeks. So that's another diagnosis to code. Then she desires sterilization. Anytime we have a procedure, remember, we have to have a diagnosis to show the medical necessity of why that procedure was done. So we also have to code the diagnosis for sterilization. And then the procedure for that sterilization is the tubal ligation. So we will talk about that when we get into coding. Here's the op report showing how they did sterilization. They did the Pomeroy type. And as we're looking at the op report, remember, inpatient coding, we use PCS codes. So with that, we have to know our approach. So our approach with this one is what is the intent of the operation? Remember, that's always our root operation. So the intent is the occlusion, right? That's what we're doing with the tubal ligation. And then the approach is open because it says right here, an infraumbilical incision was made through the skin, subcutaneous tissue, anterior fascia, and peritoneum. So they actually made an incision to access the fallopian tubes. Then each fallopian tube was grasped, it was blocked, and then it was ligated with that suture to do the ligation. So when we get to the procedure, we need to remember those tips from the op report. Let's go look at the rest. This is just the path report confirming what the surgeon took out. So bilateral fallopian tubes, right? Both the normal right and left side are present in the path report. So that's good. Okay, health history. This usually comes to the hospital from the OB's office. So this is collected during the 9 months the surgeon OB is seeing the patient. I shouldn't have said surgeon, sorry, OB. Okay, so we use this just for if there's something pre-existing that we needed to pick up, but there was really nothing noted. So that's why I went so fast on that one. Okay, so the interpartum record is part of the hospital delivery documentation. So we have that our patient's membranes ruptured at midnight, right? We knew they ruptured prematurely. It said right here. Her labor started at 2 a.m. She was completely dilated at 15:40. Delivery time was 15:48, and then the placenta was a few minutes later. There was a fetal scalp electrode, so they monitored the baby with a fetal scalp electrode. Over here under complications, you'll see we have a nuchal cord that's commented on, and the fetal heart rate they were watching because it did get to 140. So the baby was spontaneously born. There weren't forceps or vacuum extraction used. Episiotomy, it says none. Urinary cath, that's just, again, standard. And then third stage is during the delivery of the placenta. Everything was intact, normal. Blood loss seemed to be normal. So here again, fetal heart, they were monitoring that because the baby did have some early decelerations. Again, nothing too abnormal. The nuchal cord, again, was noted here that the baby had that around and was entangled. Let's look at the delivery notes. So the patient had spontaneous rupture of membranes this morning. She labored, contractions didn't really become regular, however, and so finally augmentation was carried out. So that's just medication, usually Pitocin, that they give to the mom to augment or speed up, right, her labor. She was already in labor when her membranes had ruptured, but wasn't progressing, so they just gave her some Pitocin to speed it up. The patient then made slow but steady progress to about 5 centimeters and dilated more rapidly. When nearly complete, she was taken to delivery and delivered spontaneously. A male infant, which was 6 pounds, 8 ounces, 18.5 inches long, appeared to be somewhat early as the due date would indicate. The baby cried spontaneously, however, did well. There was a nuchal cord, which was slipped over the shoulders during delivery. Again, that's not uncommon. Like I was saying in the lesson last night, for anyone who has gone through a vaginal delivery, usually the OB will ask the mom to stop pushing once the head has presented and check to see if the baby is entangled in the cord called the nuchal cord, which is when it's wrapped around the baby's neck, and the physician will just unwrap it so that it doesn't compress the baby. We still code it as a complication, even though it didn't cause any ill harm. It's still a complication of delivery. The placenta separated appeared to be intact. Some calcification was present. The estimated blood loss was 350 cc's. Electronic fetal monitoring was carried out with abdominal leads for most of the time, but scalp electrode being applied in the later part. So that's two different kinds of electronic monitoring that we're going to pick up when we code. And the second part was because they noticed that the fetal heart had some decelerations. So the record was fairly normal with good beat variation throughout. There were several instances of early decelerations and one or two late, but generally the record was reassuring. So even though they were monitoring, they didn't see anything that caused concern, right? Patient has been doing well. She's on regular diet and voiding. She recovered well from the anesthetic, discharged to home, prescriptions given for the Motrin, and she's going to return in 1 week. Okay, so let me bring up 3M, and we are going to go through coding this in 3M. Okay, so our patient was 39. For admit date, discharge date, again, remember to just make sure you put current year in so that you're getting current year code sets. If you put in a previous year, you're going to get codes that were valid that year. We're going to keep it as a DRG finder. That's what we want when we're coding inpatients. Then we're going to hit continue. Patient disposition is just where the patient went when they left our facility. So when we discharged her, she went home. So we're going to hit 1. Okay, admit diagnosis. Again, remember, this is just a placeholder. You can put the same code as the principal diagnosis. You can put a chief complaint. You can put the principal diagnosis here, and then again, principal diagnosis in the principal diagnosis spot. For the sake of time, I'm just going to enter the normal delivery and pregnancy code, which is the 080. Again, this patient was not normal pregnancy, but this is just a placeholder. So I'm just putting that in to demonstrate how we can just enter a code here. So we're going to hit continue. Okay, now we're going to add diagnosis. Let me move my screen over so you can see. Add diagnosis. Let me move the screen back, and you can see that it changed it to principal diagnosis instead of admitting. So principal is always the first listed diagnosis on an inpatient account. So our patient came in because she had premature rupture of membranes, right? So I'm going to do pregnancy. If I can spell pregnancy. Number 2, we're going to do complicated by number 4. And it was complicated by premature rupture of membrane. So let's see if I can spell that under E, spell premature. Yep, premature rupture of membranes. I'm going to hit number 3. She was only 36 weeks, so we're going to hit number 3. It happened at midnight, so it was within 24 hours, so we're going to hit number 2. And then she was 36 weeks, so 3rd trimester, so we're going to hit 3 again. And yes, we would like to code the weeks of gestation because we're supposed to code that when we're coding a pregnancy or delivery, right? So we're going to hit number 2, and our patient was 36 weeks along. So we're going to hit 36 and hit enter. And now it's asking me, did the patient deliver? Why, yes, she did. She delivered a single male infant, right? So we're going to hit 2 for single, and the baby was alive. So we're going to hit live born. And yes, we actually have more complications, right? I told you guys there were 3 total. So we coded the premature rupture of membranes. Now we have to code the delivery complications. So we're going to do delivery. And okay, first I have to hit no here. I apologize. I noticed I'm under pregnancy complications. We don't have pregnancy complications to code. We have delivery complications. So I don't know if I can get to the correct code in 3M. So I'm going to hit no more pregnancy. But now it's crosswalking us to our delivery. So yes, we had a delivery and it was normal, right? Our baby was delivered without any vacuum, forceps, so we're going to hit normal. We did have fetal monitoring, right? So we're going to hit number 9. and it was monitoring. Number 2, and it was the fetal heart. So number 1, it was the rate of the heart, so heart rate, number 2. And remember, we have 2 to code here. They did it through the scalp, and then they also did the abdomen. So we're going to do external, and then, yep, we have another one to code. We're going to go through the same steps. I'm going to back up actually and see if I can hit these both at the same time. No, it won't let me. Okay. So we will do the abdominal one next. Okay, so looking at this, we don't have all our codes yet, right? So we need to add the 2 delivery codes, complicated care. So I'm going to add diagnosis. We're going to do delivery, childbirth, labor, complicated by. So preterm is the first one we're going to do because it should have been 40 weeks, right? And we had 36 weeks. And we don't have to code the gestation again because we already coded that. You could, it's not going to do anything. You're not going to get the code twice, 3, and we'll just delete 1. But I'm going to hit no, do not wish to code. And we don't have to code the outcome of delivery. Again, we already coded that, so I'm going to hit no. I'm going to do the other fetal monitoring here because we only could do the internal one before. So products of conception, we're going to do the rate, number 2. And this one was just on the abdomen. Okay, no more procedures. And I'm going to hit continue. And you can see we still have to do the nuchal cord. We have the premature rupture of membranes, the premature delivery, but we don't have that nuchal cord. So I'm going to again add diagnosis. Again, my term is delivery, childbirth, complicated by, with other complication, I'm going to hit number 4. I'm going to come to B and spell nuchal cord. There was only 1 baby, so we're going to hit number 2. It was not compressed. It did not say it was compressed, so we're going to hit number 2 without compression. We don't have to code the weeks of gestation. Again, we already did that. We already coded the outcome, so we're going to hit no. There's not any other complications to code, so we're going to hit no. Okay, so I'm going to hit no procedures. We already have all our delivery procedures. Now, we are going to add the sterilization. That's the last thing we have to code. So sterilization, we're going to do number 2. And then she had a tubal ligation, so we're going to do number 4. They didn't use a fallope ring or a clip, so we're going to hit number 3. And it was bilateral, right? It was both the right and the left fallopian tube, number 3. It was open because we made that incision. Okay, so we have our diagnosis for the sterilization, showing the medical necessity of why it was done, and then the actual procedure for it being done. Now I'm going to hit continue. Okay, let's look at our codes. So again, the admit diagnosis, I just put that as a placeholder. We could put 042.013 as the admit diagnosis as well, but our 3 diagnosis codes, I'm going to click and drag this one up, are the 042.013 for the premature rupture of membranes, the 060.14 0 for the premature delivery, because again, she was at 36 weeks. Then she had the nuchal cord around babe's neck. That's 069.81x0. Then we have our 3 Z codes, right? The outcome of delivery. So what came out of mom when she delivered? Well, she delivered one baby who was alive. So that is Z37.0. Then we have to show how far along in the pregnancy she was, which she was at 36 weeks. That's the Z38.36 for the weeks of gestation. Then we have to say, oh, by the way, she desired sterilization. So that's the Z30.2. And then if we come down to the procedures, we have the normal delivery procedure, which is the 10E0XCZ. And she desired that sterilization, so they did that tubal ligation, which is the 0UL70ZZ. And then we have our 2 FA1 fetal heart monitoring codes, right? One was on the scalp, one was on the abdomen. Okay, I hope this is helpful.